you. And Yoshi, I am Dr. Bhende's fellow, the amazing surgeon you saw. And I saw this patient back in LVPI a couple of years ago. It was a young guy with diagnosed as uveitis, complicated cataract, couldn't see anything, got a B scan done, couldn't see, make out much. Yeah, there is a detachment. So I finished the vitrectomy and I get shock of my life and I see this. And I thought, let's do something different. And I ended up putting a proline suture because I could not dare to cut the angioma. I thought, let's do something interesting. And I ended up putting a proline suture, and I did the fibrotic ligature of the feeding vessel, as you can see here. And this was something which I had never seen, never heard of. And I ended up doing this, and to the best of my surprise, everything really went on well. You can see no bleeding, nothing. I fixed the retina, and this patient really did well. And 3 months later, he ended up having a recurrence from inferior part. Then when I took him in again, and as you can see that when I was doing the second surgery here, the whole thing was fibrotic, and I went and did the retinectomy and removed this angioma. And this patient eventually did really well, almost 2000 till I saw him, and we had almost a follow-up of I think 3 to 3.5 years. So this is something which I thought I should share, of a concept of fibrotic ligature of the feeding vessel. This was something interesting.
Jay, you are lucky because
Wonderful.
Mahesh and I used to do previously long back, and
Uh-huh.
whenever we try to ligate those, this angioma will draw blood supply from somewhere else. They just don't leave it.
Yeah,
So
I, I was lucky because it was a solitary angioma. If it was multiple angiomas like your case,
yeah,
I don't think we can think of doing it.
so,
It was a solitary angioma,
yeah.
so I was lucky.
Yeah, Dr. Yoshi, what he said, actually, yes, first choice, and generally quite sometime rather than dissecting angioma, sometime we do buccal. I have a couple of cases maintaining 6-7 point vision, but both vitrectomy and supported with a buccal from outside, because certain angiomas, they are so big, and they are in choroid also is a part of it. There are reports suggesting that you scrape choroid and retina angioma off, leaving bare sclera as well. There are reports. But that's a too extensive a surgery. So, but yes, buckle is definitely an option if things work out.
A segmental
Definitely.
buccal and vitrectomy combined is a very good approach, sir.
Yes, yeah.
Yeah.
Oh, I
Yeah.
had
Any other thoughts?
one question I had. Is it? I mean, you control the bleeding, but has it happened that you have not been able to control it?
Well, not yet, sir, because what happened? I don't remember that ever I lost case because of 8 or not, some 10 or 11 cases maximum I would have done now, but not remember ever I lost the case yet because of bleeding.
So would you have considered injecting PFCL earlier?
No, because see, I wanted to remove all the membranes, and see, when you have already breaks and you're already trying to actively peeling the membrane up, which is fibrotic, there is a possibility that PFCL may will end up entering the subretinal space, pulling here and there, and then removal that become messy. So
You see,
unless I am sure, I removed the membranes.
Yes, sorry. Immediate, impulse is to inject PFCL, but we should avoid that because it will go into subretinal space.
And
Vinod,
also
quick
PFCL does not work really as a tamponade, because PFCL does not have as high surface tension as you get a gas or air. So it's not a good idea to stop bleeding. PFCL doesn't really not that a good
Yeah.
But yeah.
Yeah, PFCL is a good third end only once membranes are off.
Yeah, correct.
Vinod,
right.
any quick comment?
Yeah, I think I presented a case in LVPI Masterclass Surgical Symposium we had. So I've done around 5 cases now. 2 were really bad to begin with, so they did not do well. But subsequent cases I started doing earlier. I did 3 cases, and all of them are doing well. It's really difficult to eat them up. So now nowadays what I do is I increase the pressure intermittently to 80, and then cauterize the surface of the tumor, and once it is stopped, you can start dissecting it again with the cutter. So with the help of 25 gauge cutter only, I've been able to dissect all the tumors I've done till now. So we don't have the time, but I would have loved to share the video. It's a little longish.
Perfect. Yeah,
Sir,
maybe
so
next
that is
time.
what I asked, sir. Why we could not use the diathermy on the surface when it was bleeding? even on the angioma? Will it not stop?
It will.
Well, because these are the high flow lesions, very, very high flow lesion. And see, you may not get time that enough to whole thing coagulate together because tumor is large. Even those larger vessel, as you saw when I was coagulating it, the entire vessel, if you go and get one go, somewhere one edge remains open, and once you start flowing, then you're lost. Okay. So tiny vessels are okay. So I ensure you say your diathermy is clean. You ensure that is really working, and you have temperature is very high. Once you go all out, just puncture whole thing off there. That's what you look at it. You gave a chance, you start using, and directly angioma is size, looking at it and very high flow. You will not be able to coagulate entire thing. That's the reason even when they do laser, the TTT try about whether like depending on size, whether you want 2 or 3 millimeter size of lesion, and then, but that's a cooking, that's a slow cooking sort of thing. That's a different than direct diathermy coagulation, because I wanted to dissect it with a straight with a diathermy, not coagulation, and then use a cutter to cut, because I'm not sure whether eventually whether whole thing is closed and coagulated. So if I use a cutter, maybe somewhere I would have left behind part of it, and you start using, then it's become messy.
If time permits, can I show a little half minute?
Vinod, we have very short time for another heroic surgery.
I'll just make a quick
Hemant
comment
sir,
there.
last comment. Yeah.
Generally, most of these angiomas have multiple feeder vessels. So it's always, it always has this greater tendency to bleed. So it's very tough to know which feeder, where it is coming from. So a lot of these have multiple feeder vessels, generally never one.
Yeah, I have right now a patient with 3 feeder vessel. We did the PDT for him. All right, let's move on with a next hero and heroic surgery. Anirudh, thanks PV sir for fantastic case and discussion.
Thank you so much. Thank you.
Great.
Anirudh, go ahead.